All right. Hey, everyone. Thanks for tuning in to Noon Conference today. So we are going to do another cold case. This one's going to be presented by Jason John, one of our second years. Our 3 or 4 presenters, depending on IT issues, are going to be Mark Scarpinato, one of our interns, Michelle Knies, one of our second years, and then third years. Michelle's one of our third years.
Yeah, I was about to say, Danny, we've been promoted.
Michelle is very much one of the third years and future chiefs, along with Jason. And then Will Silkworth, one of our third years, and Devang, Amin, one of our second years. So without further ado, Jason, go ahead and take it away with our case for the day.
Awesome. So can everyone hear me right now? Yes? Okay, excellent. So what I'm going to do is I'm just going to present this in like little short segments of information, and then I'm going to stop talking and let the discussants kind of give their thoughts as we go along. So this case that we're talking about is a 45-year-old man who was found down in his home. His last known normal was around 7 a.m. on the day of admission. And at that time, he spoke to a family member over the phone, and they thought he sounded pretty much normal. And then around 10 a.m., so 3 hours later, his family members went to his residence and found him confused and then unresponsive. He was brought into the emergency room, and he was noted to have some like vague, intermittent upper extremity flexion, hypertonia. So they ended up giving him a total of 8 milligrams lorazepam and Keppra. And then he was admitted to the MICU, immediately intubated for airway protection. And at this time, there's no family immediately available for further collateral history.
Perfect. Thanks, Jason. I think that's a really good first piece of information. All right, so for our discussants, what are you guys thinking about when you hear this initial HPI for a patient found down?
Yeah, this is Mark. I think from my perspective, I just want to make his last because that makes a change. And does he have neuro history? This sounds very neuro-y. It's encephalopathic. But then you got this kind of confounded thing for being tubed for benzos for his maybe post-ictal state. I don't know. So that's kind of where my heads went right away.
Okay, perfect. I hear. So neuro history, want to know past known normal, thinking about how the benzos played into it. I like it. How about for our second and third years? What are you thinking when you hear this history?
Yeah, I mean, I think we want to just do a workup of altered mental status first, but certainly like syncope here merits additional workup. We do call a lot of things like neurogenic syncope when they're not. This sounds concerning, so let's hear if he had any incontinence or tongue biting or anything else that points us toward neurogenic.
Okay. And when we're thinking about this history right now, altered mental status, found down, these kind of characteristics, how are you guys centering your initial thought process? Like, where are you centering your differential diagnosis right now?
So anytime I hear altered mental status and found down, I always wonder if it's something going on within the body or something they did to themselves. And so I always want to know like a really good drug history, especially if there's history of seizure. Does he have history of alcohol use? Is he withdrawing and then seizing? Did he take something weird? What home meds is he on? So that's usually, and then I don't know, I like labs because labs usually start to point you in one direction. Either is there something toxic or metabolic going on?
And point up their glucose is super easy to get, so we can just get them now.
Yeah, perfect. I think that's great. So let's just be really direct about what we're all talking about here, because I think we're all talking about the same thing. Let's talk about what our found down differential is. All right. So Mark, we'll start with you. What are some things you think about when you hear that someone's been found down?
Well, you know, coming from Wisconsin, alcohol, drugs, something like that. So something that they're going to take themselves.
Great. So alcohol and drugs, and it sounds like what you're talking about is more of like a toxin-mediated category, which is fantastic. Awesome. What else are we thinking about when we think of our found down differential?
If something really catastrophic has gone wrong in the brain that can cause somebody to be down and completely altered, so like a huge bleed or profound cerebral edema.
Great. So like brain catastrophes. Awesome.
And then like
And then,
metabolic derangements, DKA, for example. Any of the other electrolytes can also be off.
perfect. And I see team X and D are saying like sugars, so hypoglycemia. I really like that. That's a great thing to always consider. And then Devang, what else in that metabolic history are you talking about?
Like if he's really hyperkalemic,
Profoundly hyponatremic.
yeah, profoundly hyponatremic, profoundly hyperkalemic, his heart could have stopped.
Yeah.
With that arrhythmia.
Great.
You can add uremia in there too. I don't know if he's a kidney guy, but uremia can definitely do that.
Perfect. And then I think all of you guys have sort of mentioned this, but we've also got our cardiac stuff, right? So we mentioned syncope, we mentioned some arrhythmias, and then, MI, like huge MI, heart catastrophe found down. Anything else you guys want to add to this initial found down differential?
A seizure. It seems like that's what the ED thought.
Perfect. And then Ava's chiming in with some good stuff. So within this kind of cardiopulmonary realm, PE or profound hypoxia.
Mm-hmm.
And then just a throwback to Mark's hometown. The other thing I always like to think about in here, and this could be really anywhere, but is like profound cold. So hypothermia is another thing I always think about.
Mm-hmm.
Cool. All right. So how do you guys want to go through working these things up?
I want vital signs because that's immediately going to rule some of these things out.
Perfect. Okay. So let's do this. Corey, I'm going to send it back to you. So Jason, go ahead and give us sort of the next set of information that you've got.
Sure. And I just wanted to add something, if I could be so bold, kind of parallel to what you were talking about. One mnemonic, I don't really like mnemonics unless I do. And one mnemonic that I've heard of specifically for encephalopathy, not so much for syncope, is MIST, M-I-S-T. M being metabolic, I being infectious, S being structural, and T being toxin. Doesn't cover everything, but it's kind of a quick and dirty mnemonic that I've heard of, at least. So as far as like the next set of information that we have, so the past medical history for this gentleman, he has a history of type 2 diabetes, as well as alcohol use disorder. His home medications are Tums, glimepiride. I never prescribe it, so sulfonylurea. Glimepiride. Sorry, I couldn't get my tongue to work.
Nailed it.
Thank you so much. Thank you for saying that. Advil PM, Glargine 25 units nightly, and then metformin. There's been no new medications or recent medication changes. And then regarding his alcohol use, so he's been a heavy drinker for years, but had recently been sober for several months. However, 1 week ago, he relapsed and has been drinking pretty heavily over the past week. He does have a history of alcohol withdrawal. Not so sure about seizures, like may or may not have had him before. He never has been hospitalized. And then his wife has noted that he's made some like vague allusions to suicidal thoughts recently. No other substance use history and no pertinent surgical or family history.
Perfect. Jason, that's an awesome set of information. Great. So let's go back to the whiteboard here. And Mark, what are you thinking when you hear this med list?
Yeah, I think that med list combined with suicidal ideation, I think, it's an insulin overdose. He's got insulin. Is he active or, alcohol? I think there's a lot of different ways, especially with those meds. And so the other thing is it could just be unintentional, because insulin and sulfonylureas can cause profound hypoglycemia together. So it could just be an unintentional thing.
Yeah, I think that's a great thing to always keep in mind. If you see a patient on a sulfonylurea, especially as they get older, those are really associated with hypoglycemia, and that risk actually gets even higher if the person's on concomitant insulin as well. So that's always a great thing to be on top of. And then for our second and third years, what do you guys think about that alcohol history?
Don't love it. So anytime somebody's a super heavy drinker, if he suddenly stops, that can be really dangerous. Or if he's drinking a ton and not eating and continuing to take his insulin and sulfonylurea, as alcohol alone can already increase your risk for hypoglycemia, but can also cause some other really profound electrolyte abnormalities. So there's a lot of dangerous things going on here.
Yeah, great. So drinking and stopping is bad. Electrolyte abnormalities can always happen. I think that's great. Jason, anything you wanted to add based on that, based on sort of the teaching points we just talked about?
No, I don't think so. I'm really glad you guys took a look at the drugs that cause hypoglycemia, and then obviously the alcohol history is standing out like a sore thumb, and I think that's great.
The metformin also scares me a little bit, because if he's a bad alcoholic and he is also like not eating or drinking and he gives himself a really bad AKI, he could get a really critical lactic acidosis from the metformin, and so that's where I would love some labs, which I'm sure you'll get to.
I know.
Great.
This might be a judgment thing.
Jump ahead.
Feel free to tell me I'm un-PC, but was this patient a patient you would expect to have toxic alcohol ingestion or not?
All I know about him is he has a profound heavy alcohol use, and over the past week he's been drinking heavily.
Great.
No less, no more.
Perfect. So I think let's stop here and let's create a differential based on these first kind of two pieces of information, that HPI and then our meds and our social history. And let's say, I think that it's great to have a 10 to 12 list differential, but let's do our top four and let's see if we can really focus in before we start examining this guy and ordering some labs. So what are we thinking?
I think number one has to be hypoglycemia. And let's say two, either toxic alcohol ingestion.
Mm-hmm.
Perfect. And what else are we thinking? Let's round this out with like two more.
I would throw alcohol withdrawal seizures as like number 4. I don't think it's super likely. It doesn't fit with this overall picture, but.
Okay. And Michelle, just to be clear for our interns, what about his overall picture doesn't fit with an alcohol withdrawal seizure?
So it sounds like it was fairly acute, and then he remained profoundly altered. And typically people that are in alcohol withdrawal seizure, like family will have noticed that they stopped drinking, and then they come in, they seize, but they regain like some degree of, they're usually not in like status. So just the profundity of being found down without return to consciousness is a little bit weird to me.
Sure. Yeah, I think that's great. So found down without having a complete return to consciousness, maybe a little bit different. I think these top 3 are fantastic. Anything else?
Can I add a fourth? I know
Absolutely.
medicine people, but I think some structural neuro abnormality has to also, like before we get the scans, I don't think we can exclude that.
Perfect. I think that's great. What I really like about what you guys did about this differential is you guys hit the things that we absolutely cannot miss, which are hypoglycemia. That's life-threatening, and that's something we can fix immediately. You guys hit the alcohols based on his history, sort of common things being common. Alcohol withdrawal seizure, again, could kill this guy. And then structural neuroabnormality, right? Something that as medicine doctors, we're not going to be able to do anything about, but we can certainly find the right person for that guy. I think that's fantastic. Anything else anyone wants to add before we move on to some vitals and an exam? Cool. All right. Corey, I'm going to send it back to you. All right, Jason, what do you got for vitals and exam?
So he is afebrile. His heart rate is in the 110s. His blood pressure is in the 140s over 80s. And then he's already intubated, and he's on minimal ventilator settings, and there's no issue with the vent. On exam, he's intubated and sedated. No evidence of head trauma. Both of his pupils are 2 millimeters and sluggish, 2 to 3 millimeters and sluggish. He doesn't have any scleral icterus. He has no JVD. His cardiopulmonary auscultation are unremarkable, as is his abdominal exam. And then his neuro exam, other than being GCS3T, there's nothing, that we can capture. Again, he's intubated and sedated. He does have trace pitting edema and bilateral lower extremities to the mid shin. And his skin exam doesn't show any jaundice, rash, lesions, wounds.
Perfect.
I know he's 3T, but can we get a little bit more on the neuro? Like, you're just like, he's completely sedate. He doesn't withdraw from pain. He doesn't do anything. You like try to kill his thumb and it doesn't move. He just doesn't move.
Yeah, we just started propofol on him and we are not getting anything moving. He's in a propofol induced coma.
Cool. I think that's a really important point that Mark brings up, though, is there's definitely different degrees of people who are altered, sedated, and quote unquote non-responsive. It sounds like this guy has a pretty good reason. He's on propofol, but response to pain, squeezing the thumb as hard as you can, sternal rubbing. These are all things that we should incorporate into our physical exam anytime we're concerned someone is non-responsive or altered. And then for the upper levels on the call, what do you guys think about being intubated in a minimal vent settings? Like, how does that change the way you think about an intubated person?
I mean, there's two reasons we intubate. One is for airway and one is because there's a problem with the lungs. And in this guy, it's clearly just a problem with him protecting his airway.
Yeah, excellent. Yeah, I think anytime we hear intubated on minimal settings, I think clarifying what those settings were, not necessarily in this case, but usually that's an FiO2 in the 30 to 40 range and a PEEP in the 5 to 8 range. And just recognizing that when someone's on those settings, it was likely for airway protection and not necessarily a parenchymal lung abnormality.
Yeah, the single thing otherwise I'd like to know is, did anyone get a sense of his respiratory rate before he went on the vent?
And Devang, why do you ask that?
Like opiate overdose, potentially. I mean, we can't really tell much off the peoples because he's sedated, but it just triggered in my mind that we should think about opiate overdose.
Yeah, absolutely. And what's kind of a magic number for you where you see that respiratory rate? It could be a mix-up question or whatever, but what's a magic number where you see that respiratory rate and you think opiates?
For me, I would say like 8. It's where I get really concerned. Maybe less than 10.
Perfect. Yeah, I think that's spot on. I think anything less than 10.
I have an answer for that. His respiratory rate was in the 30s prior to being intubated.
Great. That answers that question.
Which is kind of interesting because we're concerned about maybe he took something, and so aspirin can make you hyperventilate, which would make me a little bit nervous about that. But
Great. Yeah, Michelle, tell us a little bit more about that.
I mean, that's all I had to say about it.
Right. That's perfect. Yeah, so aspirin causes like a metabolic acidosis and a concomitant respiratory alkalosis, which is why people end up breathing really fast depending on the stage at which you are in your aspirin overdose. And so I think that's a really good thing to clue in on. All right, Jason, are you ready to give us some labs here?
I'm ready as I'll ever be, Dr. Gergen. I have a lot of data, but I'm going to try to start with the stuff that I think any reasonable doctor would order. So as far as his BMP, sodium was 136, potassium was 3.4, chloride 94, bicarb 22, BUN 10, creatinine 0.8, glucose 416, calcium 9. And then as far as LFTs, total protein 7.7.
Keep going.
Albumin 4.2. T-Billy 1.6. D-Billy 0.3. AST 55. ALT 48. ALK-Phos 86. White count 8.9. Hemoglobin 16.5. Platelets 165. INR 1.2. An ABG that was done like before he was intubated, so like reflecting his actual respiratory status, pH 7.42, PCO2 41, PO2 80, lactate 5.5, A1C 13.1. He had a UDS that was positive for ethanol, but an ethanol level was less than 10. Tylenol and salicylates were undetectable. And then, let's see, a UA just showed glucosuria. Blood culture sent. Chest x-ray looks completely normal with the ET tube in appropriate place. EKG showed sinus tachycardia. And a CT, oh, do you want to hear the CT head? Because I heard them ask for it.
Yeah, CT head sounds good.
A CT head and neck was without, CTA head and neck was without acute abnormality. And the CT chest, abdomen, pelvis only showed hepatomegaly with hepatosteatosis.
Great. All right, that is a wealth of information, but some really, really good stuff on here. So for one of our third years, when you guys get just an overwhelming amount of data coming out of the emergency department, what's kind of your thought process for how you work through those labs?
So look for the red arrows, which sounds silly, but honestly is super helpful. So in him, overwhelmingly, things are not that abnormal with a couple super important exceptions. So I think when we calculated his gap is 20, which is high. His lactate is high. And then the rest is fairly normal. So those are the things that I immediately was zeroing on. And then specifically looking for what did I think would be abnormal and isn't. So his creatinine is normal, which I'm reassured by. His glucose is high, but we can get a BHB, make sure he's not in DKA. So kind of going down that road.
Yeah, I like to take a look at like acid-base status to see if the metabolic picture matches up with the respiratory picture.
Great. And Devang, what do you think about his acid-base status right now?
So he has a gap, but actually no metabolic acidosis here. I mean, unless he has a gap acidosis and then a concomitant like metabolic alkalosis that just balances out. And then his respiratory function is completely normal, like CO2 is normal. So he's not compensating for anything or have any primary respiratory issue, but he's ventilated. So it's hard to tell.
Perfect. So as a throwback to one of Mira's talks, just because Devang brought this up, as a throwback to Mira's talk last week about the delta-delta, let's go ahead and do this delta-delta right now. So Jason, give me that BMP one more time.
The BMP?
Yep.
So 136, 3.4, 94, 22,
Okay, and hold on.
10.8,
Hold it.
416.
And then hold it right here.
Great. And the anion gap was 20. Okay. So does one of the Mark or one of the upper level residents on the call want to walk us through either the add back method for the delta or give us their other method?
So the quick and easy like add back method would be you like determine how different the anion gap is from 12. So we have a difference of 8. Add that back to the bicarb and see if that corrects your bicarb. If it does, you have a pure gap acidosis. If it doesn't, you get something else going on.
Perfect. Yeah, that's awesome. So what Devang just did here, just for those that are unaware, is what we call the add back method. And so he did it perfectly. And so the add back method here gives him a number of 30. And so technically anything between 24 and 30 is considered normal, but we're right on the edge of having a concomitant metabolic alkalosis. So his bicarb is actually higher than we would have expected. So maybe he's got a metabolic alkalosis, but he's probably somewhere between just a regular acidosis and an alkalosis. And then, so that's interesting, right? So this guy's got an anion gap, but he doesn't have an acidosis. What do we make of that?
No, I don't. Stop it, Malia. Your attitude sucks today. I'm sorry.
Somebody should mute their mic. So we wonder if we're missing something and we'd like to get a serum. Awesome.
Perfect. Jason, do you have that information for us?
I do. His serum osm is 389 on the lab.
Great. And is that high or low for our participants?
Pretty freaking high.
Yeah.
Yeah, that is in the pretty freaking high category. I like it, Devang. Cool. I like it. So let's do this right now. I'll be honest. For the first 3 years of residency, I got this number and I was like, oh no, I got to do something with it. And I refused to dedicate the formula to memory until I did, and it was incredibly helpful. So what is the formula that we now need to use?
Like 2 times sodium plus BUN over 2.8, is it? And then plus glucose over 18, something like that. I don't know if I'm remembering the exact numbers.
Something
Yeah,
like
so-
exactly that, Devang.
Yeah, Devang, that was a revelation. So
I tried to
Devang
teach my team about delta today. They became very angry with me.
So what Devang just told us was the formula for a calculated serum osm. And so what it is it's your sodium, like Devang said, times 2, plus your glucose over 18, plus your BUN divided by 2.8. And then you also, if the person has ethanol in their system, you have to add in an ethanol, and I believe you divide the ethanol by like something like 3.5 or 3.7.
It's actually 4.6. I think you need to get on Devang's level, Dr. Guru.
4.6. And Peter Heisen brings up a great point that MD Calc is helpful, and I second that. MD Calc will always help you with this instead of writing it out. Jason, if we throw this guy's stuff in here, what do we come up with?
Just doing the math in my head real quick and not using MD Calc. 299.
299. Great. And so our calculate. So then to take this, what do we do next with this 299 and our 389 number? So we subtract the serum minus the calculated. And so I am probably going to mess up this math, but it's 90. And so is 90 high or normal for this?
High.
Yeah. So this man has a very large osmolar gap. Awesome. So what do we for our participants, what do we make of this information?
So
Drink something he shouldn't have.
yeah, there's something charged that is adding to the serum osms. We're obviously not measuring in the calculated osms, so we're missing something that his body has, and we need to figure that out, and that'll help us with the diagnosis.
Great. Mark, I think that's a really good way to put it. So basically missing something his body has in it. That's great. Cool. So let's now, any other labs you guys want real quick before we move on and talk about what we might be missing in his body? I'll say one of the things I started doing after doing Denver Health ICU was that for all my found down patients, I usually get a CK as well. There's almost no evidence to back up that decision on my part, but I think having a CK can maybe sometimes help clarify how long the person's been down for. So if they've been down for hours, maybe their CK is in the thousands versus if that CK is nothing, you can say, hey, maybe they weren't laying on the ground for that long. But that's just a personal stylistic thing on my part.
In this case, Dr. Gergen, he did not have a CK checked during his hospitalization. Just throwing that out there.
Cool. Great. All right. So do you guys have a way of thinking about how to approach that large osmolar gap?
Go to Google.
Go to Google. I like it. And what do you think? What is Google or UpToDate going to tell us in terms of like a breakdown process or how to think about this more?
I think you have to figure out, I mean, this is a huge difference in this is a huge osmolar gap, but you do have to account for your albumin. And that will give you some amount that you're allowed to have as an osmolar gap. I don't remember the amount.
Yeah, great. I think one of the ways that one of the MICU attendings taught me how to do it was if you have a large osmolar gap, the next thing you want to look at is whether you've got a large anion gap metabolic acidosis or you've got, basically a normal anion gap. And this helps kind of center the next part of your clinical decision-making. I think the VA Team X and D mentioned this in the chat, but what are the things that give us a large anion gap and a large osmolar gap?
Like ethylene glycol, methanol.
Perfect. Yeah, great. So methanol and ethylene glycol are definitely two of those. And then the other one I'll throw in there is propylene glycol as well, can do it. And then what are the things that give us a large osmolar gap but a normal anion gap?
I think it's like isopropyl alcohol can do that.
Yep, isopropyl's on there. And where do we find isopropyl alcohol? Like just as in terms of like our everyday lives?
Rubbing
Rubbing
alcohol.
alcohol.
Yeah, Eric says CVS, rubbing alcohol, the kitchen sink. Yeah, isopropyl alcohol's on there. And then the other one that's on there is ethanol. Yeah, so Team A throws it in there. Ethanol's on there as well. And then one of the weirder things, what's the kind of other weirder thing that we find a normal anion gap and a large osmolar gap? Not thinking about the alcohols. This is a what am I thinking question, but we call it, kind of like a pseudo osmolar gap. Yeah, so VA Team X and D said paraproteins, exactly. So a pseudo gap, which then you break down as some paraproteins. So they've got something else, like Mark said, in their body. Or if you are profoundly hyperlipidemic, you can be, that can falsely lower your sodium, which affects the calculation. So always something to keep in mind. What thoughts do our participants have right now based on sort of the data we got back and where this whole conversation is led?
I think we're all pretty concerned that he, with his alcohol history, this super large anion gap, very large osmolar gap, that he drank a toxic alcohol, and he should probably get on the phone with poison control and consider starting. I've never used it, but methazole versus talk with renal. His kidneys still work, and then also send off the toxic alcohol panel.
Perfect. I think that's great. Other thoughts before I come back to that?
Start an alcohol drip. I know that's old school.
Sorry,
Give him
Mark, say
some
that one
beer.
more time.
Can we start an alcohol drip? I know it's old school, but
Start an alcohol drip. I like that.
I see an interesting question from Eva in the chat that just came up.
Jason, go ahead and read that for me, just because I can't see the chat.
Well, Eva asked if we tried to do anything about his lactate before trying to get a sense of his anion gap.
Sure. Yeah, I think that's great. What did you guys? So let's go back to his labs here. What do you guys think about that lactate? Jason, brings up a good point. The other guy has stable vitals right now, but he is intubated and he does have a lactate, so we should probably talk about it. What do you guys make of that?
I mean, there's always an underlying cause driving lactate, right? And so, to me, fixing the lactate is fixing the underlying cause.
Well, and part of his lactate, so when you drink, it's like the NADH conversion, you lose that cofactor. And so if he has been having poor PO, he's going to drive a lactate and then not be able to clear it. If he's thiamine deficient, sometimes that can cause you not to be able to clear lactate. So I would be tempted to attribute this, since he doesn't have other signs of sepsis or something, as not necessarily like not being able to use, not sepsis, but is related to his alcohol use and maybe being dry. So I would start with.
Maybe I can provide a little bit more information to answer Eva's question. So the lactate, he got some fluids coming in the door. His lactate actually went up to 7 and down to 5 and down to 4 and up to 5. So the lactate just kind of lingered in spite of some of those interventions we were doing, at least in the first 24 hours. And then the anion gap also remains high. And the serial blood gases remained stable as they were, with that pH of 7.4. And yeah, so his pH remained pretty stable too.
Perfect. So I think just to come back to what Michelle said real quick and what Mark had said, lactate's always from something. And so there's types A and type B lactate. And so for our participants, what's the type A lactate from?
Like end organ dysfunction, your cells are not utilizing or able to use oxygen.
Yeah, great. So hypoperfusion, end organ damage. I think that's great. That's like, so the type A lactate is you're not perfusing. And then, like Michelle said, the type B lactate, that's your alcohols, that's weird things that are sort of what I kind of refer to as like non-perfusion related. So things that are separate from being hypotensive, essentially. And I'd say, just looking at this guy's vitals and what Jason was saying, the fact that it didn't change with fluid, we're probably thinking about a type B lactate here, but always good to make that distinction. I think there was also something in the chat here. Bill says that I would add his lactate's a little out of proportion to his anion gap. I'd expect a smaller anion gap anecdotally with a lactate of 5. Yeah, which I would agree with. Okay. So Michelle, you had said that you wanted to call tox, perhaps call renal and send off some toxic alcohols.
Yeah, I love tox. They're so helpful.
Yeah, I completely agree. The tox fellows at our institution are fantastic. And let's say, Mark, you'll be the one who's calling a lot of consults this year. You're picking up the phone to call the tox fellow overnight. How are you gonna call this consult?
I think it's pretty simple when you say you've got a intubated, found down guy who's 3T right now, and you've got a huge osmolar gap. Could you please come and take a look at him and tell us what we need to do?
Yeah, great. I think that's good. I think one of the things you did there that was nice was you were really upfront with the question. So found down, large osmolar gap. How do you help us out? Awesome. And then Michelle, you said you wanted to call renal.
Well, I don't know if it's necessary. I have not actually managed a toxic alcohol, but I think you can give flumeprazole, but then you can also dialyze it off. So depending on how sick he is. But.
Sure. So I guess the question here then is are we giving this guy flumeprazole? And does he need HD? And just to give our discussants a quick second from talking here, people throw in the chat kind of where everyone's leaning, whether this guy needs flumeprazole, whether this guy needs HD. Take about 30 seconds and let's see if we can get a consensus.
Danny, I'm hoping there's some debate here. I would love like a good old controversy. Urine, Eric Rudolfker. There's some urine. And it looks normal.
Cool. So Bill, not a whole lot of discussion, but so we'll throw it back to the participants. Bill says flumeprazole is harmless without risk, which is true. Flumeprazole is truly a harmless medicine. It's actually not that expensive. Peter says no HD yet, which is correct. Yeah, this guy, we'll talk about this in a second. I think Jason will fill us in, but this guy does not need HD. We'll talk about why. And then for our participants, would you guys give this guy flumeprazole?
So could completely be an intern thing, but like flumeprazole doesn't do anything with the toxic alcohols. It just prevents the breakdown of them. So you're not actually getting rid of them. You're just getting the body more time to figure out what to do with them. Correct? So like that would be my indication for dialysis is that there's a toxin in the body that we can't get rid of effectively. And his statin neurofat has gotten back.
Yeah, I think that's a good point. I think Team A brings up that the aldehydes are the danger, not the alcohols. I'm going to be honest. I'm not an expert in toxic alcohols, but I agree. I think it's not the initial product that's the problem, right? It's the breakdown, like you said, and so it does just sort of give us more time to figure it out. And then I think coming back to this guy's labs, right? If we look back at his initial labs, his anion gap was 20, so not substantially elevated, which I think probably points us perhaps a little bit away from these three. And the big thing about these three right here is these are the ones where you definitely need to give flumeprazole. And you almost always, if they have end organ damage, need to dialyze.
Danny, I'll just chime in here. Methanol breaks down to formic acid, and I think it's ethylene glycol and propylene glycol that break down to glycolic acid.
Perfect. Love it. Cool. So we got about 15 minutes left, 5 or 10 minutes left. Do our participants feel comfortable putting their nickel down on a diagnosis here before we send off the toxic alcohol panel?
Yeah, the next piece of information will reveal the diagnosis.
Go with isopropyl alcohol.
Yeah, I'll second.
And Mark, what are you thinking?
I think so. I don't know. But sure, I'll put my money on that, but not a ton of money.
I like it. That's always a good thing, is to hedge your bet.
How much are they paying the interns these days? I didn't know there was a lot of money to just distribute around, diversify your portfolio.
I think $4,000.
And Devang, go ahead, just because you initially said isopropyl. Can you just kind of talk us through kind of the basic clinical reasoning that got you to say this is isopropyl alcohol?
So, I mean, it sounds like he's drinking more. Then usually, like, having such severe ethanol intoxication does not result in this type of bound down picture. I mean, it can. Yeah, I don't have a great explanation.
But yeah, I think one of the nice things you just talked about was context clues. So Jason gave us a really good history. This guy's been drinking more and perhaps binging. And I have absolutely no evidence to back this up, but are people more likely to drink isopropyl alcohol while binging? Perhaps. And so I think that was a really nice way of using the context clues, incorporating your social history, and then coming to a diagnosis. So Jason, what do we got?
Yeah, so a couple quick comments. So toxicology was consulted on this patient. And in many centers, the toxic alcohol panel that we did send off actually takes some time to come back. So you have to make some decisions beforehand. Fortunately, I think this UCH is like the regional center or something like that for toxic alcohols. So we were actually able to get our results pretty quickly. And then, so yeah, I have those results for you. So his ethylene glycol level was undetectable, methanol undetectable, propylene glycol undetectable, and his isopropyl alcohol level was 103, which is elevated from normal being undetectable. And just around that time, either a little bit before or a little bit after, his family called us and said that they had found an empty bottle of rubbing alcohol in his room.
Wow. What do our participants have to, what kind of thoughts on that case and the ultimate diagnosis? What you guys got right?
Yeah, that was a neat case. I think we worked through some good differentials on altered mental status, being found down, worked through some acid base. It's interesting.
You got your delta back?
Sorry.
I think, sorry, this is Paul. I wanted to ask a question as well, and then maybe the chiefs can answer this question. I know that if there's a high enough suspicion that the patient has ingested toxic alcohol, but their anion gap is really high, but their osmolar gap is low, is there I mean, I know that there's a concern. If there's a concern, you treat them for toxic alcohol because you can have that sort of, there's a graph somewhere that I saw where you can have normal anion or osmolar gap, but increased anion gap, or sorry, increased anion gap, but normal osmolar gap. Does that make sense? So there's like as time goes by, as you sort of metabolize that alcohol, your osmolar gap will decrease, but the anion gap will go up.
Yeah, no, I think what you're saying is absolutely correct. And I think, Paul, you bring up a really good point that without knowing a time course for this person and without knowing how long they were down for and when the ingestion occurred, like what Michelle and Mark and Devang were saying, is call Tox and sort of let Tox help you talk through that decision. because giving fomepizole is essentially harmless, but the benefit could be substantial. And so you were absolutely correct. Depending on when you ingested it, you could see a large osmolar gap with no anion gap, or you could see a small osmolar gap if it's been a lot of time. So yeah, the time is crucial. Great point.
You know, with this case, I would be so nervous, even though he has an anion gap and a lactate, I would be so nervous with some of these alcohols not treating if we didn't have the alcohol panel back. Do you know if tox or renal like said, if we can't get it back, will we go ahead and do something empirically while waiting, or like what's the, say we don't have access to that lab?
Yeah, Michelle, I think if we did not have that information sooner, we would potentially spring into action, you know, with some more aggressive treatment, certainly like at least fomepizole earlier on. However, there were some clues, they were kind of subtle in the history that, you know, alluded to this potential diagnosis. So I actually have this excellent excerpt from the tox note that I know everyone loves to hear things just like read out loud to them. I'm hoping that the chiefs will send this out to you guys after the fact. But Danny, is now a good time to share a paragraph on isopropyl alcohol ingestion? So this is from the tox note. So isopropanol.
Jason, real quick. Let's Corey's gonna chime in.
Yeah, I was just gonna tell you one thing. So as somebody I've seen fomepizole given one time during my residency, and it was a patient that came in with ethylene glycol. And honestly, like usually even with these toxic ingestions, they usually wait till your pH actually starts to drop or you have renal failure. And so with her not having any end-stage renal dysfunction, her pH is normal. With that in itself, you're not going to usually wait to treat. And fomepizole, actually, if I'm not mistaken, is really expensive. And so I don't think it's one of these. I think it's one of these things that when they do use it, they use it when they are actually trying to prevent any further damage or prevent this patient from getting sicker. The other thing to kind of note that I have had come across as, yeah, Sam and me were the ones who actually gave this person. Sam was the one who actually gave the person fomepizole. Her name is on the orders for it. But the other thing that I think everybody needs to keep in mind too, because what'll happen when you're on the ICU, you're going to give a so not the cheapest drug out there. So the other thing to know about when you get an elevated serum osmolar gap, because you're going to get that. Somebody's going to come in acidotic. You're going to check an osmolar gap. It's just going to happen, and they're going to have an elevated osmolar gap with these patients in the ICU, and it's not always from a toxic alcohol ingestion. You're going to call tox, and you're going to check an ethanol level because these people are going to be intoxicated. And they'll tell you this once you call them, because I had to call them at least 10 times before they finally told me just to cool my jets. If they have ethanol in their system, that is actually going to, if they did even ingest a toxic alcohol, the ethanol in itself is actually going to be protective because it's going to prevent the metabolism of the toxic alcohol into the toxic metabolite. So just kind of keep that in mind too, that if this person, definitely check an ethanol level in these people. If you are concerned about a toxic alcohol, and just remember that, they used to use that like old school ways. I think the VA still keeps a few, I think they've downgraded. Now it's Natty Lights that they keep at the VA for it now, but we could maybe we get some microbrews in there for their microbrews here at the U or something. But yeah, that's just the only thing I wanted to talk about is when you kind of actually get fomepizole dialysis, and then also when you're going to give, when you have these elevated serum osmolar gaps, you have alcohol in the system, remember this protecting you. And I'm done.
All right, Jason, take us home.
Yeah, so this is from the tox note. So isopropanol, commonly known as rubbing alcohol, is an interesting alcohol in that it is not actually metabolized to an acid, unlike other, quote, toxic alcohols like methanol or ethylene glycol. It undergoes metabolism by alcohol dehydrogenase to a ketone, acetone, not an aldehyde, and therefore is not metabolized by aldehyde dehydrogenase. It is also unique in that its metabolite, acetone, is essentially benign and does not lead to end organ toxicity. For these reasons, fomepizole is not indicated in patients with isolated isopropanol ingestion. Generally speaking, isopropanol ingestions are well tolerated, aside from the fact that they make patients, quote, twice as drunk for twice as long, because isopropanol has a higher molecular weight than ethanol and is classically considered more inebriating. There's like some rare case reports of hemorrhagic gastritis and tracheobronchitis, but the management of isopropanol ingestion is generally supportive. So it was a little tough because I think this gentleman had a type B lactic acidosis in the setting of prior heavy alcohol use. And that led to his anion gap. But I think that pH being 7.4 and stably so was really reassuring that it wasn't one of the other ones, which they do cause a high anion gap, but they also cause a profound actual like acidemia. And so this gentleman, through supportive care, ended up waking up. I guess he was starting to feel the withdrawals coming on, and he didn't have any regular alcohol nearby, so he chugged a bottle of rubbing alcohol, leading to his stay at the University of Colorado Hospital.
Cool. Jason, that was an awesome case. Huge shout out to our participants, Mark, Michelle, Devang. You guys crushed it. That was awesome. I had a blast. Real quick, just so we can all kind of publish one thing we learned here. Everyone just say one thing they're going to take away from this case for the next person they see in the hospital, for our participants at least.
Next time I have a patient drink rubbing alcohol, I'm not going to be concerned unless they start throwing up blood.
Checking a serum osmols is pretty useful.
And I think,
And Mark, what do you got?
Yeah, no, I think just all of that, and because it sounds like something, to me this sounded like something neuro right away, but you always have to keep your differential wide open in the beginning. And then also, judging, I think Jason, I asked, does he look like someone who would have toxic alcohol? But, sometimes that is like a useful thing to do, is to kind of judge our patients to guide our care.
Yeah, I think that's a good point. I think really clarifying that social history and really kind of digging into the social history, always helpful. Cool. Well, awesome, guys. That was awesome. I had a great time. Thanks so much for your participation. And we'll see you guys at the next noon conference.
Thanks.
Yeah. And participants, I'll send this out to you guys, okay?